Welcome to our multimodality imaging educational sessions. My name is Dr. Valeria Duarte. I'm one of the adult congenital heart disease cardiologists and imagers. Today we're going to be discussing congenital heart disease, a general approach to moderate and high complexity defects. Before I move on to my presentation, if you have any questions at any point of this lecture, please join us by web or by text. By web, you go to pollev.com and enter DeBakey and then respond to activities. And by text, you can text DeBakey to 37607 and text in your message. We will try our best to address any questions that may come up at the end of the presentation. So without further ado, let's move on to our discussion. Today we're going to define a general approach to imaging congenital heart defects. We are going to highlight the benefits of each imaging modality, and we're going to review the importance of anatomy and long-term complications for different congenital conditions. I like to start my presentations with this graph. This graph it represents the surgical cases of a congenital surgery hospital, a pediatric hospital, and it's a summary of their cases from 1997 and 2002, and you may ask yourselves, why is this important to us? And the reason is because these patients that were operated back then are the adults that we're treating today. And I want you to pay attention to the pie chart here and see that the majority of the cases are represented by septal defect, systemic outflow issues like coarctation, LVOT obstruction, right ventricular outflow issues, pulmonary outflow issues, we should say, like Tetralogy or Fallot, and other RVOT reconstructions. But if you look at number 7 in your pie chart, then you can see that almost 13% of the cases are represented by very, very complex congenital heart conditions like single ventricles and Fontan. So we need to be prepared to image these adults, younger adults and older adults with congenital heart conditions that may have, our imaging may drive surgical interventions and percutaneous interventions. So we need to be as accurate and as thorough as possible always. So some principles to obtain an adequate study in a patient with congenital heart disease. The first rule to keep in mind is that we need to address the clinical question. Sometimes our referring physicians will send you a very specific clinical question to address, and other times this will be a routine surveillance imaging where we have to be very thorough and look at every possible feature that may need to be addressed clinically. So for this, we need to, number 1, know the native anatomy. Number 2, review the surgical history of the patient. And this is a lot of work sometimes because some of our patients will come to us after 3 operations. So the workload can be extensive, but we do need to take the time to review the clinic notes, the operative reports, and if we don't have those, take the time to call our referring physician and talk to our patient before we scan them. I always tell my team that we need to think about this imaging a complex congenital patient like an imaging consultation more than a simple test. We need to remember and keep in mind that there are different surgical approaches for sometimes the same lesion. And if the patient has undergone any of those surgeries, we need to keep in mind the long-term complications of each condition and each surgery. So we can look for them. We won't find anything that we don't look for. And we need to know the strengths of each modality and sometimes know when it's important to complement different modalities to give a a complete answer, and especially for surgical planning, transplant planning, and so forth. And then in our reports, we need to use a language that that providers from different backgrounds can understand. Congenital heart disease is very heterogeneous. Each condition is heterogeneous, and the nomenclature can be very different across different practices. So we will be addressing providers that are general cardiologists, providers that are adult congenital cardiologists, and providers that are pediatric cardiologists taking care of adults. So sometimes we need to make sure that our verbiage is clear. So we're going to use Tetralogy of Fallot as an example. This is not a Tetralogy of Fallot lecture, but I think we're going to use this condition to define the approach that we need to take when we are assessing these patients. So, as you know, Tetralogy of Fallot is the most common cyanotic congenital heart defect, and it's a condition that occurs due to the anterior and leftward deviation of the infundibular or conal septum that results in an malalignment BSD, RVOT obstruction with different levels of pulmonary valvular and subvalvular obstruction or stenosis, and exaggeration of the aortic override over the septum, and a secondary right ventricular hypertrophy. So that's what we learned in medical school. Then we need to create a list of priorities of what do we need to address. So Tetralogy of Fallot, as you know, after repair, the main issue that these patients deal with long term are pulmonary valve issues, mainly pulmonary valve regurgitation, but also pulmonary valve stenosis. So with that, we need to give a very thorough assessment of the pulmonary valve, but we also need to look at the right ventricular size and function, and we need to be accurate about measuring our RVOT dimensions. And there are other things that can happen to Tetralogy of Fallot patients, like LV dysfunction and also sometimes residual VSDs. This is infrequent, but we need to look for them because sometimes we do find them. Rarely, but we do. So most congenital heart defects are a spectrum. So not all the patients with the same defect are the same. In fact, the majority of the patients with the same defect are quite different. So the Tetralogy of Fallot is a good example of that. We can have patients with severe pulmonary stenosis, severe RVOT obstruction at one end of the spectrum, but who have an intact pulmonary trunk and intact pulmonary artery branches. But then at the other end of the spectrum, we can have patients with Tetralogy of Fallot and pulmonary atresia. So these are patients who do not have a pulmonary valve at all, and sometimes don't have a pulmonary trunk. And in some patients, to complicate things further, the pulmonary branches can be discontinuous. And the pulmonary circulation may be supplied mostly by branches from the aorta. These are also known as MAPCAs, major aortopulmonary collateral vessels. So not all the patients are the same, so that's why we need to investigate them ahead of time. So let's start to image patients with congenital heart disease. We need to know their history. And their history is usually long and complex. So let's start from the beginning. This is a patient with unrepaired Tetralogy of Fallot. It's a newborn patient, so these are pediatric views. You can see here an echocardiogram that highlights the ventricular septal defect, the overriding aorta, and the right ventricular hypertrophy. And we can further assess that with color Doppler. This is a short axis view, in looking at the pulmonary valve. You can see how in the newborn you can you can obtain high-quality images of the pulmonary valve and also of the pulmonary branches that here appear to be hypoplastic if you pay attention. Just adding color to that image, you can see significant RVOT acceleration that then with Doppler you can assess for the significance of the obstruction. So very high velocities across the RVOT. In short axis, you can assess the degree of right ventricular hypertrophy that is secondary to the RVOT obstruction. Now, when we image patients adult patients with tetralogy of Fallot, then that's a whole different story. So for starters, most of the patients will be repaired by the time we've met them. So the assessment is quite different. We need to focus on long-term complications after repair. On the other hand, these are patients that are they are bigger, their BSA is higher, so the images can be more challenging than in a newborn. So the windows may not be as adequate as they were when they were kids. And so that's one of the challenges we encounter, and we need to do our best to provide a diagnostic study. It is possible, but also a lot of times we need to complement with cross-sectional imaging. So here we can see a patient with repaired tetralogy of Fallot. If you pay attention to the septum, you can see a bright structure that is the VSD patch. Then in a 4-chamber view, that's when one of the first challenges in tetralogy of Fallot comes. We're trying to assess the RVOT function, size and function, and you can see that with large right ventricles, it's sometimes hard to get a good look at all the walls. So that's why we need to sometimes obtain images that are a bit off axis and foreshorten the left ventricle, just to assess all the walls of the right ventricle. Looking at the pulmonary valve of an adult patient is harder, much harder than looking at the pulmonary valve of a child. And as you can see, despite efforts, the images can be the windows can be challenging, but still we have a lot of resources to look at them, and I'll walk you through them. So in these patients, we can see the pulmonary valve in limited views, and we can assess for flow acceleration and pulmonary regurgitation that in this case is not as significant as it is in this case here, where we can see a dilated RVOT and severe pulmonary regurgitation. It's important to keep in mind that because of the rapid equalization of pressures, the pulmonary regurgitation jet may be faint and not last long on time over time. So it's important in all tetralogy of Fallot patients, look at the pulmonary valve frame by frame to make sure that we don't miss severe pulmonary regurgitation. Looking at these valves quickly can result in underestimation of the severity of the PR. So frame by frame always to quantify accurately. And sometimes it's helpful to obtain 3D images of the valve for further assessment. Imaging the pulmonary arteries in patients with tetralogy of Fallot, it's a great challenge. It takes a skilled sonographer to obtain this. Here we're looking at the branch PAs, the LPA, and the RPA in the patient that we just reviewed with severe PR, and we can see the flow reversal in the branch pulmonary arteries. But it's not straightforward. The Doppler Doppler imaging is very important in severe pulmonary regurgitation. You can see that the PR envelope is very different in the patient with severe PR compared to patient with milder forms of PR. The envelope has a triangular shape and reaches the baseline. Just another example here. This is an example of a very good window to look at the pulmonary artery bifurcation at the pulmonary branches. You can see here significant pulmonary regurgitation, severe with a flow reversal in the branch PAs, but you can see that the pulmonary branches here, at least proximately, are widely unobstructed, which is an important assessment to make. For imaging adult patients with tetralogy of Fallot not always means imaging repaired patients. This is a patient in his early 40s who has unrepaired tetralogy of Fallot. You can see there the aortic, the ventricular septal defect, the overriding aorta in this parasternal long axis view, the right ventricular hypertrophy. And you can see the significant flow acceleration across the RVOT tract. Okay, so in adult patients, MRI has become a very, very important tool because we need to make an accurate assessment. And speaking of the pulmonary valve, MRI allows us to evaluate the flow across the pulmonary valve very accurately. This is our flow images. You can see how we define an area of interest around the pulmonary valve annulus, and that provides us with the measurement of the flow that goes across, forward and backward, that helps us calculate the regurgitant volume and the regurgitant fraction that in this particular case was significant. Then I would like to highlight a few points. When we use cross-sectional imaging, it's very important to accurately measure the right ventricular outflow tract, because some patients may be candidates for percutaneous pulmonary valve replacement, and we need to provide our interventionalists with the measurements in systole and diastole of the RVOT and the proximal PA. So we can see here a patient with severe pulmonary regurgitation in angiography who underwent a percutaneous placement of a pulmonary valve that took care of the pulmonary regurgitation. But first to evaluate candidacy, we need accuracy in the measurements, and also to plan the procedure afterwards. Cardiac MRI is also a very accurate way to measure ventricular size and function. In our congenital population, particularly the assessment of the right ventricular size and function is very accurate with MRI. So when we are making longitudinal measurements to guide clinical decisions, we frequently obtain cardiac MRIs to quantify the ventricular size and function. This is a short axis stack across the ventricles, and you can see here a severely dilated right ventricle. Also, if you look at the labeled image of the RV, you can see that there is a patch that is dyskinetic in systole. All part of our assessment. In the short axis, in the parasternal long axis view or LVOT view in MRI, we can assess the ventricular septal defect, the ventricular septal defect patch, I should say, and we should always report the QPQS to support the lack of evidence of residual shunt. So it's important to take different views of the RVOT with MRI. You can see here clearly, you can see this patient had a large patch that is dyskinetic, and the RVOT is severely dilated. This may preclude this patient from being a candidate for certain percutaneous valves, but the interventional field of congenital heart disease is evolving, so now larger RVOT, right ventricular outflow tracts can be addressed with newer valves. So again, looking at the septum, we always perform a thorough assessment of the septum. Every patient that has had an intervention is to be thoroughly assessed for that particular intervention. And in Tetralogy Fallot, looking at, even though residual VSDs are very rare, we always look for them, and you can see that there is one here. This patient, you can see the jet between the LVOT and the right ventricle very clearly there. Another view of the defect. So as I mentioned, there is a spectrum in Tetralogy Fallot, just like many other congenital defects, and it's important to assess not only the pulmonary valve, the right ventricle, the ventricular septal defect, as we discussed. We also need to assess the main pulmonary artery and the branch pulmonary arteries. As we discussed, and as we reviewed when we're reviewing the images of our patients with repaired Tetralogy Fallot, imaging the branch pulmonary arteries by echo can be challenging in adult patients who have undergone multiple surgeries or may have a challenging body habitus. So cross-sectional imaging is key. We can see here an axial stack of images to evaluate the right pulmonary artery and left pulmonary artery branches, and we look for flow accelerations, we look for dilation, and sometimes we can use, if we want to image both branches in the same plane, we can use our MRA. If the patient is receiving gadolinium, we can use our MRA to plan an image that will show us both branches in the same plane or in less stacks. So as we discussed, in the Tetralogy Fallot, very, very important to look at the pulmonary valve function, look for regurgitation, quantify the regurgitation with by regurgitant volume, regurgitant fraction, obtains 2D images, color, 2D Doppler imaging, and 3D sometimes, and we need to go beyond the valve and assess the main pulmonary arteries and the branch pulmonary arteries for obstruction and dilation. We need to look at the RV size and function. When we're reporting the RV size, it's important to report the right ventricular end of diastolic volume index and the right ventricular end of systolic volumes, because those are the measurements that are used to make clinical decisions. And it's important to quantify the RVOT dimensions. I usually perform a stack across the RVOT, and we measure the RVOT in systole and diastole. We also provide the measurements of the narrowest area of the RVOT, which could be a potential landing zone for percutaneous pulmonary valves. patients with severely dilated RV and right bundle branch blocks with tetralogy flow, due to dysynchrony, may develop left ventricular dilation and dysfunction, so it's very important to report that as well. As we discussed, we look at the branch PAs. The VSD repair is usually very successful in tetralogy follow-up, but residual defects happen. And even when they're small, they have clinical connotations. Patients with residual ventricular septal defects next to adjacent to prosthetic material, they need to be on prophylaxis for bacterial endocarditis. So it's very important to report those, look for those and report those. So wrapping up our lecture from today, some tips and tricks that apply to tetralogy follow imaging and to most moderate and complex congenital heart defects is that we need to have the right information. Information matters in these patients. We should never take a patient to the scanner without having any information or being blind. That leads to very, very long scans. That sometimes is inevitable, but very prolonged scans trying to figure out the diagnosis, the surgeries, and for those cases, the congenital imager needs to be by the scanner, help supervising and helping the technicians acquire the right sequences to answer the clinical questions. So we need to obtain the report, the surgical and clinical notes before protocoling. It's really worth the effort. If no information available, we need to take our time to call the referring physician and talk to the patient too. Patients with congenital heart disease have been patients for their whole life, so you will be impressed on how much they know about their condition and how much their parents know sometimes about their condition. If the anatomy looks complex or confusing, then it's frequently helpful to obtain axial stacks or coronal stacks. We also do a 3D SSFP navigator that provides us with a 3D image data set that we can post-process and analyze after. It also helps us now assess the coronary origins, which is also important in patients with tetralogy of Fallot. We need to assess for all the frequent issues, complications, and associated defects for each condition. So with that, I'm going to close. I think we're a little bit earlier, so if you have any questions, please feel free to reach out. And if you encounter challenging cases in your clinical practice, this is my contact information, and I'm happy to support you in any way I might be able to. Okay. So thank you very much. I think we're checking to see if we have any questions. I think we don't. Yeah. We haven't received any questions. So with that, I'm going to close today, and I'm going to see you in our next congenital session. Thank you very much for joining us today.